it goes back to when I was a trainee, a registrar in Edinburgh in Scotland, and they have a lot of lung cancer there, and I just really liked the patients, and they were very very humble. They had often felt guilty. Many of them are smokers, and so it made you want to step towards them to try and help them out. And then the second thing that happened was that as part of my training in medical oncology, I actually double trained in clinical pharmacology, and I had an attachment to a drug company, to AstraZeneca, for 2 years. And that was exactly the time when gefitinib was being developed. And so I had been a molecular biologist before, and I could just see the way the field was going. So I had this combination of patients that I liked and science that excited me that was about to explode in that particular disease, and that was what made me go in that direction. Of the first wave of checkpoint inhibitors in terms of whether PD-1 or PD-L1 is better, I think there is absolutely nothing to choose between them. I think we've seen very similar efficacy. I think we've seen very similar toxicity. I'm just not convinced that is a differentiator. In terms of, for example, in the USA, in the second-line setting, we have atezolizumab, pembrolizumab, and nivolumab, all licensed in the second-line setting, and people are making choices on the basis of frequency of giving, so every 21 days as opposed to every 14 days. Requirement in the license for PD-L1 testing, only pembrolizumab requires that, and at the end of the day, cost. So efficacy and toxicity are being very much viewed as equivalents in that class. So we use biomarkers to predict efficacy for immunotherapy in a very different way from the way we use biomarkers to predict efficacy for targeted therapy. So in targeted therapy, it's kind of a categorical variable. You've either got it, you get the drug, or you don't have it, you don't get the drug. Whereas the markers that we have are imperfect, but they allow us to enrich your chances of benefiting from the drug or decrease the chances, but it doesn't go to 0 and it doesn't go to 100%. So we use that for prioritizing the line of therapy. And at the moment, the only thing that people are using is the PD-L1 immunohistochemistry assay. It's imperfect, and it's imperfect because you can have really high levels, and at best, maybe you've got a 45% response rate. You can have essentially 0, and you might still have a 10% response rate. And I think the new area that people are going to really get into is maybe those levels are contextual. And I don't mean about tumor mutation burden, although that's another thing. What I mean is really high PD-L1 levels in the presence of a driver oncogene may mean something completely different and have much less predictive value for benefit from immunotherapy. And I think that is perhaps one of the next waves coming out, that maybe we're going to have to put it into... Maybe PD-L1 levels in a never smoker should make you think twice about whether you can just use the data that's coming out of a general unselected study. So what are the side effects of immunotherapy that you have to be aware of? Well, many people have none. I mean, in some people it can be great. You know, some a little degree of pruritus, itching is not too difficult. You can treat that with a topical hydrocortisone or even an antihistamine. You know, occasionally people will get low-level colitis, and you can manage that with sort of Imodium or Lamotil. You know, it's only when, you know, that rare sort of, 1 in 20 people, that sort of 5% or even less, who get severe side effects. And then really the key is steroids, holding the drug, and if needs be, sometimes you can actually use, anti-TNF antibodies. So the latest advances in non-small cell, that's quite a lecture in and of itself. I think you can break it down. So you can say, okay, in terms of the targeted therapy, are we adding any new targets? And we are. We are slowly adding very thin slices of the pie. NTRK gene rearrangements, less than 1% of lung cancer. RET gene rearrangements, some interesting data where the fusion partner, whether it's KIF5B or not, seem to influence efficacy to at least one RET inhibitor. There's two schools of thought. Either that's because KIF5B has got some other second driver pathways associated with it, feedback loops where one drug isn't enough, or it may just be that KIF5B is a really powerful driver, has higher levels of RET, and if your drug isn't that potent, it's not enough. And so we'll have to wait and see if some of the more potent RET-specific inhibitors can work on that. The other thing is, in those targeted therapies, acquired resistance. So we're finding some of the mechanism of acquired resistance For, EGFR, we've nailed T790M. MET amplification, I think, is being honed down into exactly who is having MET as their second driver. It's a relatively small population. You have to use high-level definitions of what you call MET amplification, but we're seeing some efficacy there. And then, a lot of stuff is works in progress. And then immunotherapy, which is, immunotherapy is one of this thing where you have an early success. 1 in 5 people has a fantastic response. It lasts for a long time. And everyone thought, okay, this is great. And now we just have to increase that percentage by combining it with other checkpoint inhibitors. And that has been a disaster. It feels like we are going cooking and we are opening the cupboard and randomly combining ingredients together and hoping it tastes good. And so far it doesn't taste good. So this is my advice, and this is what I say to the fellows and the trainees that work with me, is that you can be the first to see something. Okay, whether it's a side effect, whether it's a pattern of disease that no one has ever seen before, and what you have to do is believe in yourself. Okay, and then you have to prove it. So anyone can think of a question. Okay, ever since we're children, we come up with questions, but you have to break it down into, first of all, ask the question. The second thing, is it a question that is feasible to answer? Okay, if to answer your question, you have to do a 1,000-patient randomized phase 3 study, go find another question. And finally, after you found the feasible questions, you have to say which are the important questions. Because there's not enough time in your life to answer every question. So if you can go through those steps, ask the question, make it feasible, make it important, then you can change the world. And you can do it with observations now in 10 patients, 20 patients, and maybe you're going to be the first one to see it.